Similar to the gasoline that cars and trucks need to run, and the electricity needed by a light bulb to produce light, the human body needs its own form of fuel to function, and that is food. Through the process of digestion, the digestive system transforms food into nutrient molecules that are small enough to be absorbed by the lining of your gastrointestinal tract. As students and future healthcare professionals, it is essential for you all to understand the process of digestion so that you can assess and properly treat your patients with digestive disorders like acid reflux and heartburn. Heartburn is a burning sensation that occurs when the stomach acid gets regurgitated into the esophagus. This pain can be so severe that a patient who is experiencing it for the first time may actually think they're having a heart attack. By having a solid fundamental understanding of the process of digestion, you can advise your patients on lifestyle changes that can prevent disorders of the digestive system, like eating in moderation and taking antacids to prevent heartburn. And throughout this lecture series, we're going to cover the major organs and accessory components that are associated with the digestive process, as well as important physiological aspects of digestion. Our digestive system is essential to keeping our body functioning properly. And there are four main functions of the digestive system. The first is to take in food through the mouth. As we take in food, we chew the food, then we swallow the bolus of food, and it travels down our esophagus and goes into our stomach. Our stomach then has stomach acid that breaks down the food into nutrient molecules. And then from our stomach, it travels into the small intestine. And the small intestine is where 90% of food absorption occurs. And then from our small intestine, it travels to our large intestine, and then out through the rectum and the anus. And so the process of excretion is important to rid our body of any indigestible remains. The organs of our digestive system can be classified into two main groups. The first being the alimentary canal, which is also known as the gastrointestinal tract, or GIT, and the second is the accessory digestive organs. So let's begin by talking about the gastrointestinal tract, or GIT. So this is a continuous muscular tube that runs from the mouth all the way to the anus. And this is responsible for digesting food and breaking the food down into smaller fragments, and then absorbing these fragments through gastrointestinal lining into the blood system. And you can see the organs depicted here for you. The organs of the GIT include the mouth, the pharynx, the esophagus, the stomach, the small intestine, the large intestine, and the anus. Everything else depicted here falls into the classification of being an accessory digestive organ. So the accessory digestive organs include the teeth, the tongue, the gallbladder, and then the digestive glands that help to produce secretions that break down the bolus of food. So these digestive glands include the salivary glands, the liver, as well as the pancreas. The processing of our food involves 6 essential activities. The first is ingestion. So this is simply the process of eating. So we have a cheeseburger in front of us, we open our mouth, and we put the cheeseburger in our mouth. This is ingestion. We are ingesting the cheeseburger. The second is propulsion. Propulsion is the movement of food through the gastrointestinal tract, and propulsion includes swallowing, as well as a process known as peristalsis. So peristalsis is the major means of propulsion of food that involves alternating waves of contraction and relaxation. So our gastrointestinal tract has to undergo contraction and then relaxation in order to propel our food distally down the gastrointestinal tract. And next will come the mechanical breakdown stage. And the mechanical breakdown stage includes chewing, mixing our food with our saliva, the churning of food in the stomach, and then segmentation. Segmentation is a local constriction of the intestine that mixes the food with the digestive juices, such as the stomach acid. And then after the mechanical breakdown stage, we actually have the digestion stage. So in digestion, there are a series of catabolic steps that involve enzymes which help to break down the complex food molecules into chemical building blocks, which are readily available for us to absorb in the fifth phase. The fifth phase is absorption. And this is the passage of digestive fragments from the lumen of the gastrointestinal tract into our bloodstream or our lymphatic system. And then finally, we have defecation. So defecation involves the elimination of indigestible substances through the anus in the form of feces. Here we are going to talk about the organization of the digestive system and the relationship of our digestive organs to the peritoneum. The peritoneum is a group of serous membranes that are found within our abdominal cavity. And the peritoneum consists of the visceral peritoneum and the parietal peritoneum. So the visceral peritoneum is the membrane on the external surface of most of our digestive organs, while the parietal peritoneum is the membrane that lines the body wall. And between these two, there's a fluid-filled space called the peritoneal cavity. And the fluid that's found within the peritoneal cavity lubricates the mobile organs. We also have what's called a mesentery, and this is a double layer of peritoneum, and the layers within the mesentery are fused back to back. So the mesentery extends from the body wall to the digestive organs, and it's very important as it provides roots for blood vessels. It also provides roots for our lymphatics and our nerves. And the mesentery suspends the organs or holds them in place, and also is essential for storing fat. And organs can be grouped into classifications of being intraperitoneal or retroperitoneal. So if the organs are intraperitoneal, these are located within the peritoneum. If they're retroperitoneal, they're located outside of or posterior to the peritoneum. Some examples of the retroperitoneal organs include most of the pancreas, the duodenum of the small intestine, and several parts of the large intestine. Whenever there is an inflammation of the peritoneum, it results in a condition known as peritonitis. And peritonitis can be caused by multiple factors, including a piercing abdominal wound, a perforating ulcer, or if your appendix ruptures. And what happens in peritonitis is the peritoneal coverings begin to stick together, and this helps to localize the infection and basically creates a breeding ground for bacteria and other pathogens. And this can be very dangerous and even lethal if it becomes widespread. So the main treatment is to remove the debris by giving megadoses of antibiotics. All of our digestive organs have the same 4 basic layers, which are also known as tunics. And from the inside out, you can follow along with me on this picture, we're going to name the 4 basic layers, and then we're going to talk about each one of their functions specifically. So from the inside out, let's begin by talking about the mucosa. The mucosa is the tunic layer that lines the lumen, and the functions of the mucosa differ based on which layer we're talking about. So the mucosa can be further subdivided into the epithelium, the lamina propria, and then the muscularis mucosa. So as I mentioned, the different layers can perform one or all 3 of these next mechanisms, which I'm going to mention here. So the mechanisms are secretion, absorption, and protection. So for the secretion component, the tunic will secrete mucus, could also secrete digestive enzymes as well as hormones. And the tunic will aid in absorption of the end products of digestion. And it also has a protective feature as it protects us against infectious disease. So the epithelium specifically, this is simple columnar epithelium, and this epithelium has mucus secreting cells that are found throughout most of the gastrointestinal tract. And please note that the mouth, as well as the esophagus and the anus, are made up of stratified squamous epithelium. And the epithelium will also secrete mucus. So it protects our digestive organs from enzymes, and the mucus secretion also eases food as it's passing through the gastrointestinal tract. And the epithelium also has the capability to secrete enzymes and hormones. For example, in the stomach as well in the small intestine, the epithelium can and does secrete enzymes and hormones. And then the lamina propria. This is made up of loose areolar connective tissue, and there's a rich supply of capillaries that are located here. And the lamina propria is needed for nourishment as well as absorption. And it also contains lymphoid follicles that help defend against microorganisms. The follicles are part of the MALT system. Remember, MALT was the mucosa-associated lymphoid tissue. And then finally, we have the muscularis mucosa. And this is a smooth muscle that produces local movements of the mucosa. So now we're going to move out of the mucosa and go externally towards the outside-most layer. And we're going to talk about the submucosa. So the submucosa consists of the areolar connective tissue, and it contains blood as well as lymphatic vessels, lymphoid follicles, and the submucosal nerve plexus that supply the surrounding gastrointestinal tract tissues. And within the submucosa, there is a high abundance of elastic tissues that help our organs to regain shape after storing a large meal. Moving more externally, we have the muscularis externa. And this is the muscle layer that's responsible for segmentation and peristalsis. Please note that fact, as that will be a test question. The muscularis externa is the muscle layer that's responsible for both segmentation as well as peristalsis. And the muscularis externa also contains an inner circular muscle layer and outer longitudinal layers. So the circular layer thickens in some area to form sphincters, which allow for opening and closing to occur. And moving more externally, we have the serosa, which is the outermost layer. And this is made up of the visceral peritoneum. Remember, we said that the peritoneum can be segmented into the visceral as well as the parietal peritoneum. And the space in between those two is known as the peritoneal cavity that's filled with peritoneal fluid. So again, the serosa, this is formed from areolar connective tissue, which is similar to what makes up the submucosa, and it's covered with mesothelium, which is a single layer of squamous epithelium in most of our organs. However, the serosa is replaced by what is called fibrous adventitia in our esophagus. And this is a dense connective tissue that holds the esophagus to the surrounding tissues. There are many different arteries that are involved in supplying blood to our digestive system and our digestive organs. And I don't need you to know every single artery depicted on these cartoon schematics here, but I do want you to know the differences between the splanchnic circulation and the hepatic portal circulation. So the splanchnic circulation includes arteries that branch off of the aorta to serve our digestive organs. So these are the hepatic, splenic, and left gastric arteries, as well as the inferior and superior mesenteric arteries. I'll say that one more time. The arteries in the splanchnic circulation include the hepatic, splenic, and left gastric arteries, as well as the inferior and superior mesenteric arteries. Our hepatic port of circulation is responsible for draining nutrient-rich blood from our digestive organs and delivering that blood to the liver for processing. So I just want you to know the differences between those two circulation systems. However, don't focus on knowing each individual artery, but do know the arteries that are associated, that I mentioned, with the splanchnic circulation. The gastrointestinal tract has its own nervous system, which is known as the enteric nervous system. It's also called the gut brain. And it actually contains more neurons than the spinal cord does. And the gut brain is made up of enteric neurons that communicate extensively with each other. And this is the major nerve supply to the gastrointestinal tract that controls gastrointestinal motility. So the enteric neurons, they make up a bulk of two main interconnecting intrinsic nerve plexuses. And these two plexuses can be divided into the submucosal nerve plexus and the myenteric nerve plexus. So the submucosal nerve plexus is responsible for regulating the glands as well as the smooth muscle in the mucosa, while the myenteric nerve plexus is responsible for controlling the gastrointestinal tract motility. So the enteric nervous system participates in both short and long reflex arcs. So the short reflexes are mediated by the enteric nerve plexus, or the gut brain, and they respond to any type of stimuli that is found in the gastrointestinal tract. And the long reflexes are a little bit different. They respond to stimuli that arise inside or outside of the gut, such as any type of stimuli that may arise from the autonomic nervous system. So I hope you have heard the term associated, or the phrase associated with the parasympathetic nervous system as rest and digest. So the parasympathetic system is responsible for enhancing the digestive process. So if the parasympathetic system is enhancing the digestive process, what do you guys think the sympathetic system is doing? The sympathetic system is responsible for, when it's activated, it's responsible for inhibiting digestion. So always remember, parasympathetic, rest and digest. And then sympathetic is fight or flight. So as I mentioned, there are many different types of stimuli, both inside and outside of the gastrointestinal tract, that can both stimulate and inhibit the neural reflex pathways. However, there are three main key concepts that regulate gastrointestinal activity. The first is that digestive activity is provoked by a range of both mechanical as well as chemical stimuli. So even the external stimuli, so even seeing a cheeseburger presented in front of you, or smelling those delicious aromatic McDonald's French fries, that could stimulate the receptors in the gastrointestinal tract walls to respond. And the way they respond is they can stretch and they can change their osmolarity. The pH can also be altered. And that could cause a whole systemic reaction. Secondly, the effectors of the digestive activity are the smooth muscle and the glands. And when they're stimulated, the receptors initiate reflexes that stimulate the smooth muscle to mix and move lumen contents along the gastrointestinal tract. The reflexes can also activate or inhibit the digestive glands that secrete the digestive juices or hormones. And the third key concept for you to know is that there are neurons, both intrinsically and extrinsically, that are involved, as well as hormones that control the digestive activity. So again, there are intrinsic controls and there are extrinsic controls. And the intrinsic controls involve the short reflexes. These are the enteric nervous system reflexes. And the extrinsic controls involve the long reflexes, and the long reflexes are mediated by the autonomic nervous system. And there are also hormonal controls. Hormonal controls are mediated by hormones from cells in our stomach and our small intestine that stimulate target cells in either the same or different organs to secrete or contract. Now we are going to begin discussing some of the functional anatomy of the digestive system. And we're going to begin by talking about the mouth. And as you all may know, the mouth is where food is chewed and mixed with the enzyme-containing saliva that we produce on a daily basis that helps us to begin the process of digestion. And this is also where the swallowing process is initiated. So, in addition to the mouth, there are also associated organs that help in the chewing, the salivation, and the swallowing process. And these associated organs include the tongue, the salivary glands, as well as the teeth. So the mouth is also called the oral or the buccal cavity. And it's bounded by our lips anteriorly, our cheeks laterally, our palate superiorly, and our tongue inferiorly. And the oral orifice is the anterior opening of the mouth. And the walls of the mouth are lined with stratified squamous epithelium. And these cells are tough because they have to resist a lot of abrasion. And the cells of our gums, as well as our hard palate and part of our tongue, are keratinized for extra protection. So our lips and our cheeks. Our lips are also known as our labia, and they're composed of fleshy orbicularis oris muscle. And our cheeks are composed of our buccinator muscles. The oral vestibule is the recess internal to the lips and the cheeks, and it is also external to our teeth and our gums. And our oral cavity proper lies within our teeth and our gums, and our labial frenulum is the median attachment of each lip to our gum. So also within our mouth we have two palates. We have a hard palate and a soft palate. So the palates form the roof of the mouth, and we're going to begin by talking about the hard palate. So this is formed by the palatine bones and the palatine processes of the maxilla with a midline ridge cartilage called raphe, or raphe. And the mucosa is slightly corrugated to help create friction against the tongue. And our soft palate is a fold which is formed mostly of skeletal muscle. And the soft palate closes off the nasopharynx during swallowing. And laterally, our soft palate is anchored to our tongue by the palatoglossal arches. And it is also anchored to the wall of the oropharynx by the palatopharyngeal arches. And the area in between the palatoglossal and the palatopharyngeal arches is called the farces, and the palatine tonsils are located in the fauces. And then we have the uvula, and the uvula is a finger-like projection that faces downward from the free edge of the soft palate. The tongue occupies the floor of our mouth, and it is composed of interlacing bundles of skeletal muscle. And it serves many functions, including gripping, repositioning, and mixing of food during the chewing process. It is also involved in the formation of the bolus, which is a mixture of food and saliva. And the tongue helps to initiate the swallowing process. It is heavily implicated in speech as well as taste. And there are both intrinsic and extrinsic muscles of the tongue. The intrinsic muscles are responsible for changing the shape of the tongue, while the extrinsic muscles alter the tongue's position. Now, if you all try to touch the roof of your mouth with the tip of your tongue, you'll notice that your tongue is kind of fixated in one position, and there's a little cord-like structure underneath your tongue in the medialmost portion, which is known as the lingual frenulum. And this little cord-like structure is responsible for attaching our tongue to the floor of the mouth and keeping it there. So the superior surface of our tongue bears these peg-like projections of the underlying mucosa called papillae. And there are many different types of papillae or papilla. I say papillae, you say tomato, I say tomato. So the filiform papillae, these give the tongue its roughness and to provide friction. And the test question I always ask about the filiform papillae is that you all have to know that this is the only one that does not contain the taste buds. And this is responsible for giving the tongue its whitish appearance. So all the other papillae have taste buds, but the filiform papillae is the only one that does not contain taste buds. So then we have the fungiform papillae, and these are mushroom-shaped, and they're scattered widely over our tongue. And the vascular core of the fungiform papillae cause the reddish appearance of our tongue. And then we also have vallate papillae, also known as circumvallate papillae. And there's about 8 to 12 of these which form the V-shaped row in the back of the tongue. And then finally we have the folate papillae, and these are located on the lateral aspects of the posterior tongue. And you can see all these different papillae depicted on this slide here for you. And the last thing that we'll talk about in the tongue is what is known as the terminal sulcus. And this is the groove that's located posterior to the vallate papillae. And this marks the division between the body and the root of the tongue. So the body of the tongue is the portion that resides in the oral cavity, while the root is the posterior third that resides in the oral pharynx. And please note that the terminal sulcus do not contain papillae, but they're still bumpy because of the existence of the lingual tonsil, which lies deep to its mucosa. Ankyloglossia is a congenital condition in which children are born with an extremely short lingual frenulum. Remember, the lingual frenulum is that little cord-like structure that attaches the bottom portion of our tongue to the floor of our mouth. And ankyloglossia is often referred to as tongue-tied or fused tongue. And there is a restrictive tongue movement that results of this congenital disorder that distorts speech. And there's a very easy surgical procedure that the patient can undergo where the surgeon will simply snip the frenulum, and this will allow the patient to then speak normally. So our salivary glands produce saliva, and saliva has many different functions, including cleansing our mouths, helping us to dissolve food chemicals for taste processes. Saliva also moistens the food and compacts it into the bolus, which allows for the food to be more manageable as it travels down our gastrointestinal system. And it begins the breakdown of starch with the enzyme amylase. So most of our saliva is produced by our major salivary glands, or our extrinsic glands, which are located outside of the oral cavity. We also do have minor salivary glands, which are scattered throughout the oral cavity, and these augment slightly. The major salivary glands include the parotid, submandibular, and sublingual glands. So the parotid glands are anterior to our ears and external to the masseter muscle. The parotid duct opens into the oral vestibule next to the second upper molar. The submandibular glands are medial to the body of the mandible, and the duct opens at the base of the lingual frenulum, that little cord-like structure on the bottom portion of our tongue in the medial aspect. And then our sublingual glands are anterior to the submandibular glands underneath the tongue, and these open through 10 to 12 ducts into the floor of our mouth. So the salivary glands are composed of two types of secretory cells. We have the serous cells, which produce the watery secretions, enzymes, ions, and a little bit of mucin. And we also have the mucus cells, which, as the name implies, produce mucus. So the parotid and the submandibular glands contain mostly serous cells, but the sublingual gland consists mostly of mucus cells. And on the right-hand portion of the screen here, this is a histological stain that shows you the mucus cells and the serous cells. So remember, the parotid and the submandibular glands, those are the ones that consist mostly of the serous cells, while the sublingual glands consist mostly of the mucus cells. The patient you see in this slide here has a diagnosis of a clinical condition known as mumps. And mumps is an inflammation of the parotid glands caused by the mumps virus or the myxovirus. And this is a very common childhood disease, and it can spread from person to person through saliva. So the patients may present to the clinician complaining of pain when they're trying to open their mouth or when they chew food. They may also exhibit a moderate fever, and they also may have pain when they're swallowing acidic foods such as pickles and grapefruit, or when they're drinking acidic drinks such as orange juice. And this is a condition that needs to be medically treated as soon as possible so that the virus doesn't spread, and it is not only very dangerous in childhood, but it's also very dangerous in adulthood, because adult males who contract the virus carry a 25% risk of infecting the testes as well, and this could lead to sterility and cause other complications down the road. Our saliva is mostly water. It is about 97 to 99.5% water, so it's considered to be hypoosmotic. It also has a slightly acidic pH. The pH can range normally from 6.75 to 7. And within the saliva, there are many electrolytes that can be found, such as sodium, potassium, chloride, phosphate, and bicarbonate. There are also different enzymes found in the saliva. These include salivary amylase and lingual lipase, to name a few. You can also find proteins such as mucin, lysozyme, and the immunoglobulin IgA. There are also metabolic wastes, which include urea and uric acid. And there are other components, other substances, such as lysozyme, defensins, and nitric oxide from nitrates in our food to help us protect against microorganisms and infection. So there's approximately 1,500 milliliters of saliva produced every day, and the minor glands continuously keep our mouth moist. The major salivary glands are activated by the parasympathetic nervous system when ingested food stimulates our chemoreceptors and mechanoreceptors in our mouth. And then these send signals to the salivatory nuclei in the brainstem that stimulate the parasympathetic impulses along the fibers in cranial nerves 7 and 9, and then send these signals to the glands. So a strong sympathetic stimulation inhibits salivation and results in a condition known as xerostomia, or dry mouth. And simply the smell or sight of food or an upset GI tract, these can all act as stimuli to induce salivation. Anything that inhibits saliva from being secreted can promote tooth decay, and not having enough saliva in the mouth may make it difficult to talk and eat. So I'm sure you have all experienced somebody with bad breath. Bad breath is also known as halitosis, and it can be caused by numerous factors, including decomposing food particles that accumulate in the mouth that cause bacteria to flourish. And the odor that is produced is caused mainly by the metabolic activity of anaerobic bacteria at the back of the tongue. And what's going on is these bacteria are producing hydrogen sulfide. This is the chemical that gives that rotten egg smell. And they also produce methylmercaptan. This is a chemical found in feces. They also produce a chemical known as cadaverine, and this is associated with rotting corpses. And they also produce other smelly chemicals. So the best practice is to have good hygiene, to not only brush your teeth twice per day for at least 2 to 3 minutes per brushing, but also to floss at least once a day and use some type of antibacterial mouthwash 1 to 2 times per day. All of these good hygiene practices can help prevent halitosis. Our teeth lie in sockets in gum-covered margins of the mandible and the maxilla, and they are essential to the process of mastication, which is the process of chewing and tearing and grinding of food into smaller fragments. So as you can see on the bottom portion of the screen here, there are 2 formulas. I don't need you to know the formulas for the test or anything. I just wanted you to be aware of what makes up our primary or our baby or milk teeth, and what makes up our secondary or adult or permanent teeth. So these are known as the dentition and dental formulas. So the primary dentition formula, which you can see on the bottom left-hand portion of the screen, this formula states that there are 20 deciduous teeth, or 20 baby teeth, and these teeth come in between 6 and 24 months of age. And then the equation on the bottom right-hand portion of the screen, this is the equation for the secondary or adult or permanent teeth. And these enlarge and develop while the roots of the baby teeth are being resorbed from below. And as this process is occurring, as the permanent teeth are trying to come in, this causes the baby teeth to loosen and fall out. And this developmental process occurs between 6 and 12 years of age. So all but the 3rd molars, which are also known as our wisdom teeth, are in by the end of adolescence. And the 3rd molars may or may not emerge until around 17 to 25 years of age. They may emerge even later in some cases. I have a friend who just got their wisdom teeth coming in at the age of 32. This is very atypical, but please note that it is possible. And this is just the 17 to 25 is just a typical age range of when the 3rd molars start to come in. And the 3rd molars may cause crowding of the other teeth and may push on the other teeth and make them become crooked. And that is why most people get their wisdom teeth removed. It's a very simple process. I've had it done. You go under general anesthesia and you wake up an hour later and you're completely fine. Nothing to be scared of. So as you can see on the bottom portion of the screen, these formulas are denoted with different initials. So we have I, we have C, we have PM, and M. So I stands for incisors. These are the chiseled shaped teeth that we use for cutting our food. C stands for canines. These are the fang-like teeth that tear or pierce our food. PM stands for premolars. These are the bicuspids, or the broad crowns with rounded cusps that are used to grind or crush our food. And then M stands for the molars, which are the broad crowns, the rounded cusps, and these are the best grinders. So during chewing, our upper and lower molars lock together and they create a tremendous crushing force. So let's focus on the picture on the top right-hand portion of the screen that shows our tooth structure now. So each tooth has 2 major regions, one being the crown and the other being the root. So the crown is the exposed part above the gum line, and this is covered by enamel, which is the hardest substance in our body. And the crown is heavily mineralized with calcium salts and hydroxyapatite crystals. The enamel-producing cells degenerate when the tooth erupts, so there's no healing if the tooth decays or cracks. And this is when you get to go to the dentist and have the lovely procedure known as a filling. And now let's focus on the bottom portion of that picture and talk about the root. And the root is the portion that's embedded in the jawbone, and this is connected to the crown by the neck. So our canines, incisors, and premolars have only one root, and the first upper premolar often has two. The first two upper molars have three roots, the first two lower molars have two roots, and the third molar roots vary. They're often a single fused root. I just told you that for your knowledge. You don't need to know for the test how many roots each of the molars has. That's just for your knowledge. And if you're taking this class and you're interested in dentistry, you'll definitely need to know that. But for this class here, you don't need to know how many molars have, or which molars have how many roots. We also have what's called cement, and this is calcified connective tissue. The cement covers the root and attaches it to the periodontal ligament. The periodontal ligament forms the fibrous joint called the gomphosis, and this anchors the tooth in the bony socket. The gingival sulcus is the groove where the gingiva borders the tooth. And we also have what is called dentin. And dentin is a bone-like material underneath the enamel. And this is maintained by the odontoblast of the pulp cavity. So the pulp cavity is surrounded by dentin. The pulp is the connective tissue. The pulp is made up of connective tissue, blood vessels, and nerves. And the apical foramen is located at the proximal end of the root. And this is the entry for blood vessels, nerves, etc. Many of you have probably experienced impacted teeth. And what happens here is a tooth remains trapped in the jawbone, and it causes a great deal of pressure and pain. And this is commonly caused by our wisdom teeth. And like I mentioned before, the way to treat this is a very common practice of surgical removal. So we are going to conclude part one of the digestive system by talking about some common tooth and gum diseases. So I'm sure many of you have experienced dental caries or cavities. What happens here is there is a demineralization of enamel and dentin from excessive bacterial action in our mouth and in our teeth. A dental plaque is a film of sugar, bacteria, and debris which adheres to our teeth. And what happens is the acid from the bacteria dissolves our calcium salts, the proteolytic enzymes digest organic matter, and this results in a hole in our tooth. And as I mentioned before, the best way of preventing dental caries from forming is to brush your teeth at least 2 times a day for a 2 to 3 minute duration, as well as flossing daily and using some type of antibacterial mouthwash at least once to twice per day. Another condition you might come across in the clinic if you decide to go into dentistry is gingivitis. And what happens here is the plaque will calcify, and this will form a calculus or tartar. And the calculus disrupts the seal between the gingiva and the teeth, and the anaerobic bacteria begin to infect the gums. The infection is reversible if the calculus is removed, but this can cause serious teeth damage if this isn't treated right away. And if it isn't treated right away, it could lead into a condition known as periodontitis. And what happens here is the immune cells of our body are going to begin to not only attack the bacterial intruders, but also attack our good body tissues. And this can destroy the periodontal ligament. It can activate different osteoclasts, which lead to the dissolving of bone and cause tooth loss. And most threatening is this can cause increase in the risk of heart disease and stroke. So the way it does this is it promotes atherosclerotic plaque formation, and the bacteria can actually enter into the blood to cause clot formation in our coronary and cerebral arteries. So people who smoke, people who have diabetes, mellitus, and also those that have oral piercings are more prone to developing periodontitis. So it is very, very important to have good oral hygiene habits and take care of your mouth and your teeth.